Welcome to the July edition of the CMR Journal Club. We had to move it by 1 week due to several reasons, so I hope that didn't cause too much trouble. We will briefly present the papers in 10 to 12 minutes, leaving some room for some time for discussion. And then there will be, if there are questions, just jot them into the chat or just unmute yourself and then speak up. So today's topic is late gadolinium enhancement for risk prediction. And we will have two very interesting papers. One on the use of late gadolinium enhancement in ARVC, and one on late gadolinium enhancement and cardiac remodeling in cycling athletes. So the background of this is we all know that late enhancement is predictive of risk, but we need to of course, for each disease or each context, understand its specific value. And the ARVC has been under, let's say, research by CMR since at least 30 years. And initially, it was all about the fat. Then we all realized, hey, the fat is neither specific nor really sensitive. Late enhancement was always a certain candidate, but late enhancement of the right ventricle is notoriously difficult. And then at a certain point, the ARVC seemed to lose its R and become arrhythmic ventricular cardiomyopathy. And left ventricular involvement was considered actually a very important part. And now, but still, there are a lot of uncertainties. So that's why I'm really happy that we have the group here from Julie Cadrin-Torigny, who with their team, who assessed that topic, and Corrado will present that. So Corrado, I'll stop sharing so that you can share your screen.
Okay,
and walk us through this study.
Certainly. Thank you very much, Dr. Friedrich, for the introduction. Thank you for the invitation, and Julia for forwarding it on to me. It's my great pleasure to present our work on left ventricular LGE for arrhythmic risk prediction in ARVC. The one disclaimer that I will add, and also just a little bit of a brief introduction, is that I'm an EP fellow right now. So I did my cardiology training in Montreal. Now I'm doing EP fellowship in New York and eventually going back to Montreal. But it is an important disclaimer because I am not by any means an imaging specialist, but do have a keen interest in how our subspecialties can work together to answer the question of arrhythmic risk prediction in cardiogenetic and especially ARVC patients. So I'm just going to glance over the introduction because we're going to, the abstract, because we're going to talk about everything in detail as we go forward. We know that the management of ARVC, one of the cornerstones of the management of ARVC is really the prevention of sudden cardiac death. And what's important for us as an EP community and a cardiology community is knowing which patients will benefit most from implanted cardioverter defibrillators, understanding that these devices, especially in young patients, are not without risk. And one of the challenges of knowing who to implant with lies in the fact that ARVC really runs a large spectrum. So back in 2019, Julia developed a risk calculator to essentially predict ventricular arrhythmia risk in ARVC patients. It's a calculator that comprised 7 variables: age, sex, syncope, T-wave inversions in the anterior leads, non-sustained VT, RVEF, and now that I'm listing them all, I realize that there's one that I forget, and the number of PVCs, the total number of PVCs on a Holter monitor. So this was a risk calculator that was developed in an ARVC patient meeting 2010 task force criteria, so the strict 2010 task force criteria for ARVC. They did, in the inception and in the conception of the risk score, analyze the left ventricular involvement to see if it was a predictor. At the time, left ventricular involvement was really only captured by LVEF. and it was determined to not be an independent predictor for ventricular arrhythmias, so it was not included in the model. This risk calculator in the arrhythmic community is now really widely implemented in clinical practice and has also been integrated into guidelines when calculating the arrhythmic risk of patients with ARVC. We do know that while this model is excellent and has been validated in patients with the classical definition of ARVC by the 2010 Task Force criteria, it has shown suboptimal performance in patients with LV involvement. To bring this over to the imaging side of things, we know that there are multiple imaging studies in non-ischemic cardiomyopathy that show that LGE predicts incident VA across the entire LVEF spectrum, and that the distribution of LGE also represents an incremental predictor of VA, with among others Andrea DeMarco's paper showing certain high-risk patterns being epicardial, transmural, and combined septal and free wall LGE as having high predictive values for incident VA. The other thing that we know is up to 50% of patients with ARVC actually exhibit cardiac magnetic resonance imaging features of LV involvement. And so our goal was to assess whether the presence and also the distribution, especially if it falls into the high risk category of LGE on CMR, can further predict sustained VA in ARVC, and most importantly, whether this can enhance the already existing risk prediction model. So our study was really an international collaborative effort. There were 17 centers included in 11 European and North American countries. What's important, as is the case oftentimes when we're dealing with rare diseases, is that this was a retrospective study that looked at already existing and already reported MRIs. As is inherent with rare diseases, it's very difficult to do a prospective study and to really have a core lab. We really want to draw on the data that's out there and existing in other centers, and so this is why this is why it was a retrospective study and not a prospective study. We included patients if they were diagnosed with definite ARVC by the 2010 Task Force criteria, if they had never experienced a prior spontaneous sustained ventricular arrhythmia at the time of their diagnosis, and if they underwent a cardiac MRI for evaluation of LGE in either the year prior to or within a year of their diagnosis, and critically before any sustained ventricular arrhythmic event. So we ultimately had 385 patients that met all three of these criteria. The CMR data, as mentioned, was retrospectively collected from the reports at the participating centers. And so we analyzed all of the reports and essentially were able to extrapolate the LGE distribution as mentioned in here. So only the imaging reports that specifically mentioned using gadolinium infusion or specifically mentioned the presence or absence of LGE were retained for analysis. And the patterns of LGE were characterized as subepicardial, mid-myocardial, subendocardial, or transmural. And of course, these were not mutually exclusive. And finally, the location of LV-LG was determined by the CMR report, description of the distribution, and it was mapped according to the 17-segment bullseye of the American Heart Association's LV model that they used to differentiate the LV segments. The variables of interest were essentially the survival time as the observed time from definite diagnosis to the first sustained VA event, and most importantly, our definition of sustained VA event, which is what's largely used in the arrhythmic community, and importantly is also what was used for the inception of the ARVC risk calculator, was either a composite of the occurrence of either an aborted sudden cardiac death, ventricular fibrillation, VT that lasted more than 30 seconds at 100 beats per minute, or needed cardioversion, or an appropriate ICD intervention. I'm just going to hop to table 1, which is going to enable us just to go in more detail about the baseline characteristics and the type of patients. Then we can also see the breakdown of patients that did have a sustained patients that had a sustained VA ventricular arrhythmia. So that's 67 of the 385, and those that didn't. What we note is that patients with sustained VA were more frequently probans. They had a greater history of cardiac syncope. They had more T-wave inversions in the precordial and in the inferior leads. They had a higher number of PVCs. They had more frequent non-sustained VT. There were also of note genetic analyses done in 354 of the 385 patients, so a very good proportion of genetic analysis. This cohort, by and large, was a cohort with a PKP2 mutation, which is more typically associated with the classical ARVC. There were some other more infrequent genes like desmoplakin and PLN and desmogliin that are that represented a smaller proportion. We do know that these genes, however, do have an association with LV involvement. So we did do a specific sensitivity analysis with respect to these genes, which I'll talk about in a little bit. And then we also saw that patients that had ventricular arrhythmias had lower right ventricular ejection fractions and had were more frequently had left ventricular LGE on the MRI. So on that subject, I'm going to hop over to the Kaplan-Meier curves just to just continue on the flow of things. First, critically and importantly, what we saw from our study and what was also found in the inception of the ARVC risk calculator is that LVEF was not an independent predictor of sustained ventricular arrhythmia. However, LV-LGE and more specifically, high-risk LV-LGE was an independent predictor of sustained ventricular arrhythmia. So then the next question of interest becomes, okay, well, was LV-LGE and was high-risk LV-LGE an additional predictor of risk above and beyond the already existing risk calculator? So I'll apologize just for jumping between things, but what we saw was that when we adjusted for the ARVC risk calculator estimated risk, LV-LGE became an insignificant predictor of sustained ventricular arrhythmia. So it actually had a hazard ratio of 1.05 with a p-value of 0.8, indicating no added prognostic value of LGE above and beyond the ARVC risk calculator. And I'm just going to show you the table. So when the other thing that we did when we analyzed this is we excluded we instead looked at each individual variable. So I'm just going to jump to the table that shows that as well. So when it comes for LV-LGE, when it's unadjusted for the risk calculator, as discussed, it does predict ventricular arrhythmias. But when we adjust for the ARVC risk calculator, it becomes an insignificant predictor of ventricular arrhythmias above and beyond the calculator. However, when we compare it to individual covariates of the risk calculator, we do show that it's a significant predictor when comparing to age, when comparing to sex, syncope, and RVEF. So what we see is that LV-LG's predictive value is actually attenuated by non-sustained VT, T-wave inversions, and PVC. So it's really attenuated by these three variables of the calculator more so than the other variables of the calculator. And the reason that the way we explain this is multifactorial, but I think the simplest way to sum it up is that when ARVC patients develop LV involvement, it's because they are further along in the progression of their disease. And inherently, as they start to develop LV involvement, which manifests with fibrosis and LGE on the MRI, it's also going to manifest with these other elements that we see often in patients having left-sided fibrosis and left-sided scar, being PVCs, non-sustained VT, and T-wave inversions. In terms of the sensitivity analyses, we had very few patients with DSP or PLN, and of these 55 patients that had these variants, only 4 of these experienced a VA event. So when we excluded these patients from the data analysis, knowing, with the big caveat that there were so few patients, it didn't change the results. Again, both LV-LGE and high-risk LV-LGE remained predictors only at the univariable level. Just bringing this to talk about what we know from other studies and just an overarching thing from our study, we did find that LV-LGE was fairly common in ARVC. 1 in 3 patients with definite ARVC exhibited LV-LGE. 1 in 4 patients had a high-risk pattern. But that overall, while it was associated with ventricular arrhythmias, there was no independent association when adjusted for the risk calculator. Simply in talking about other studies that address this question, because our study it does have some slightly different results from the other studies that have talked about this. Notably, I'm talking about Aquaro's paper and also a paper that talks about ring-like LGE. the biggest comment with regards to our study and how it differed from Aquaro's paper was that in Aquaro's paper that showed that LVLG was a predictor, what's important to note is that it was only a predictor when they used a composite parameter of LV involvement, which included LVLG, but which also included LVEF less than 50% or LV wall motion abnormality. When the three composites of that LV involvement in the Aquaro paper were taken individually, none of them were independent predictors. And then the other important thing is that 13% of patients in that study actually had a prior history of an aborted sudden cardiac death, which really hampers the applicability of that study to the primary prevention population, which is really what our study wanted to focus on. And then again, there was another study that talked about ring-like LGE, but the importance there, as Dr. Friedrich alluded to in the introduction, is that this ring-like LGE paper was really focused on a population that met the Padua criteria for arrhythmic cardiomyopathy, but not the classical definition of ARVC. So the distinction with our paper is that it really is a classical 2010 task force criteria derived cohort of patients with what we know as traditional ARVC. The biggest limitations of our paper are really just the fact that it's retrospective, so there's no core lab that's adjudicating the MRIs. There's no core lab that's analyzing the MRIs. There is some potential for discrepancies between different reports and different analyses. But it's a limitation that we accept in order to really drive the science forward for patients that have rare diseases such as ARVC, in whom we really need to draw on a wide array of data existing internationally in order to come to conclusions for such patients. And so I think that to summarize things very quickly. Patients with ARVC, we know, have high proportions of LVLG, but that LVLG was not an additional predictor above and beyond the already existing ARVC risk calculator.
Well, thank you very much. That's very interesting. And it somehow, to me, confirms that ARVC, at least if you want to stick to the traditional definition, remains complicated and remains a challenge for clinicians. And also, to me, I also always remember the saying that ARVC is not necessarily a tissue disease, but it's some call it a channel disease. But there are multiple factors, partially triggered by gene defects, that then lead to this disease. Now, a question I have is, and we will probably only have time for one quick question, and but if anybody has, then just please use the chat. So you, as someone looking at it from the EP side, what is then, in summary, the value of CMR and specifically then late gadolinium enhancement in patients with suspected ARVC? And attached to that, do you yourself believe in the concept of the traditional ARVC, or do you think that we're talking about a spectrum that includes eventually also AVC with left ventricular involvement? Because you mentioned the progression that may then lead to LV involvement, etc.
It's an excellent question. I think, cardiac MRI definitely remains a very important tool when it comes especially to diagnosing ARVC. We know that the 2010 task force criteria have major and minor criteria associated with cardiac MRI, and I think that remains indispensable to us as we try to evaluate patients as to whether or not they have ARVC. I think that LVLGE does remain valuable to us because it does indicate that most often ARVC patients with LVLG are further along the course of their disease, and that's important for us as electrophysiologists to be aware of. It is important for us to understand how these patients are going to evolve. With regards to the question of how do we distinguish this from the arrhythmic cardiomyopathy subset of patients, it really becomes there a question of nomenclature and properly diagnosing patients with the correct disease. I think ARVC is its own entity. I think arrhythmic cardiomyopathy is its own entity. I think it's important to understand the differences between these two, because I think it has important implications in the overall evolution of these patients and in their management. So I think that as we move towards the arrhythmic cardiomyopathy side of discussions, it is important to remember what a classical ARVC patient is and how they're going to progress and how they need to be managed. I do think LVLG also has very important value, because we do know that it predicts heart failure events. And there was a very nice paper about this that was published in 2022, I believe. And so I think that we as EP doctors, yes, we may be interested in rhythm, but we do have to have the whole patient and the whole patient's care in mind. And so I don't think that we can just neglect cardiac MRI or neglect the LVLGE, because then we lose sight of who the whole patient is.
Yeah. Thank you very much. We're unfortunately running totally out of time. Julia, anything very quick to add to that? And thanks for your involvement and all that.
No, thank you very much for the invitation. I agree with everything that was said. I think genotype is getting more and more important. We understand it more. This study was mainly PKP2, which is our kind of classical gene. But we are, so LG may be more useful in gene that affect more the left ventricle. The main character here is desmoplakin that we're learning more and more about. So I still think that MRI and LGE remains useful. Thank you.
Okay, thank you very much. Okay, Tilo, now it's up to you. Can you start sharing your screen? So this is a paper also very recently published. Felix Albrecht is first author, and Jitka Starekova, the last author. It's from Hamburg. It's called Cardiac Remodeling and Myocardial Late Gadolinium Enhancement in Competitive Amateur Cyclists, Insight from Cardiac MR. The important aspect for me is what I hope we can learn from that is because we know athletes, right ventricles of athletes are always a little bit stressed. they get larger over time. But we also see at the insertion points, we see late gadolinium enhancement. But what does that mean? We typically say, yeah, it's non-specific. It probably doesn't mean a lot. But I think it means something. And right ventricular strain is a candidate for making it clinically important. So I'm looking forward to your presentation, Tilo, on this topic. And thank you very much for joining.
Yeah, thank you, Matthias and Nicole, for inviting us to this podcast. Want to present our data. This data we got this data in Hamburg in the group of Gunnar, Lund. We have done a couple of other studies where we looked into triathletes and to marathon runners, and this study is really focusing on amateur cyclists. And as you just described, there's quite a few studies that show there's LGE in these patients, and then like you said, the RV insertion point, LG is quite frequently seen even in young athletes in their 20s in some studies. And our study was to look into these LGE patterns in the cyclist and also to figure out, is there any influence of the activity they are doing? Because one of the studies at least indicated that there is some, suggested there might be a safe threshold above which you could get LGE, because the triathlete study we did before showed there was more LGE in patients who had a higher cumulative exercise history and more Ironmans. So we wanted to really include only cyclists that really represent this population. We included cyclists that did at least 9,000 kilometers in the past year or averaged about 10 hours per week. And one thing that was specific for our studies, after seeing in these older studies that there is some correlation with the amount of what the cyclist is, does the cyclist motivation influence this? So the questionnaire basically looked at how motivated is somebody in a scale from like cumulative scale from 10 to 70 points and see if there is any difference in the ones who have LGE versus the ones who don't. We included in total 66 amateur cyclists with this known parameters and also 35 healthy controls, and tried to see if we see any difference in this and be able to distinguish if there are any differences between the RV insertion point or the non-RV insertion point LGs. This study is just showing you the overview of all male and female athletes. So we had 8 female athletes and 58 male athletes. And I think a couple of parameters I want to point out is just the normal volume, which is expected in the athlete's heart, where there's increase in LV LV and diastolic volume, and the left atrial volumes, which are increased, the right atrial volumes, and the cardiac mass compared to controls. So these are parameters you always see with the athlete's heart. And our exercise test, which was a spirometry, showed that our athletes had higher VO max and also higher maximal power, accounting for their better training status. Looking at the baseline parameters, other than the BMI, there was no real difference in the controls and our male athletes. One thing, what we saw already in other previous studies, is that female athletes did not have any LG in our study as well. And we had overall 30% of all athletes had an LGE, so 19 of these 58 male athletes, and 15 had LGE in the RV insertion point, and 4 had, which we term non-RVIP LGE, which is commonly seen, as you see here, in the inferior lateral wall. There has been discussion in the past, what's the cause? Is this these athletes having had myocarditis, or is this really an association with the amount of exercise? And previous studies showed that, and we'll go a little deeper into this, how we saw this in our data. So as a first comparison, we looked into how LGE cyclists different, LG plus cyclists different to LG negative cyclists. And honestly, of all of these parameters, the only one that showed a difference was the high sensitivity troponin, which is interesting because it's a marker of cardiac damage in other pathological diseases. But even here, we saw higher troponins. And one thing I have to mention is that we told the athletes to abstain from physical exercise for at least 72 hours, because we know after high activity exercise, sometimes you can see some troponin leak. Other than that, the cardiac MRI parameters and the cycling history, and especially the mean kilometers per year or the competitiveness score here, showed no difference. Now looking further into this non-RV insertion point LGE, and there have been studies that suggested that these patients might have LGE as an proarrhythmic substrate. The Ventoux study, I think, was published last year, and they could show that there's an association with arrhythmia with this type of LGE, which they didn't see for right ventricular insertion point LGE. And if you look at this comparison, 3 things that we saw as different was like the LV mass. The LV mass was different, was higher in this non-RVP LGE group. The RVEF was lower, and the left ventricular end diastolic volume was higher. So there seems to be more remodeling in this group compared to cyclists that don't have LGE. And if you look at the competitiveness score, again, no real difference, but we saw a trend towards higher competition or like higher kilometers per year. So again, it's a trend. The numbers are low. It's only 4 patients with this, but this is in line with previous study that actually show there seems to be a difference in activity. Now to see, do we have this benign RVIP LGE? Is this really benign? Do we see a difference between those cyclists compared to the ones that have non-RVIP LGE? And here as well, we could see at least a trend of the non-RVP LGE athletes having higher troponin. Their mass was higher, and again, the right ventricular ejection fraction was lower, and the volume was higher. So this seems to be a distinct remodeling effect. And again, here the same trend we saw before is that we have higher kilometers per year. We also compared like functional parameters or like functional and volumetric parameters between males and females, and they didn't show real difference. And I think our study could show that there's somehow distinction between this non-ventricular insertion point LGE and the ventricular insertion point LGE. And this argues, or our data is in line, that it seems to be not, so when we compare the I didn't show the data, it's in the supplemental, but it's the non-RVIP LGE athletes didn't have any different parameters compared to the non-LGE athletes. So the question is this all benign? I think we could show that the non-RVP LGE has changes. The RV insertion point LGE doesn't have any. Is this just a continuum? Is this distinct? Are these patients who are more likely to have myocarditis? I think we have a lot of questions, but I think it's an important part to show that we don't see different remodeling in this RVIP LGE population. I think one limitation of our study is we don't have any follow-up data for these patients. So we couldn't evaluate them for arrhythmias if this really isn't substrate for arrhythmias. Okay, I think I'm open for discussion and questions.
Thank you very much. So even given the small limitation of the sample size, that of course would have made it better if it was larger. But I think there's still some signals, and you pointed them out. So clearly, from my point of view, late gadolinium enhancement outside the RV insertion points means something. It's too much to just declare it as noise. Whereas to me, it remains an interesting point that the RV insertion point fibrosis, we still don't know exactly what it is. So from your point of view, so do you also feel comfortable say that RV insertion point fibrosis is more frequent in these athletes than in healthy normal people? Or do you think?
Yeah, I would say so. Our data didn't clearly show that, right? We, like Jitka Starekova, did a big athlete study during COVID, had 150 athletes in there, and these were like athletes in their 20s, and good amount, I think 20 to 30% had really also this RV insertion point. The question is this like part of a continuum, right? Do you have RV insertion point? We have two who had both, and then you get later on this. I mean, it's all speculation at this point, but I think it's definitely, quite a good amount has it, and
So just to use that opportunity to give my point of view, There's some interesting research way back when from Calgary, last author Gibbons Kröker. So she looked in dogs on the stress in the RV insertion points. And even in healthy dogs, there was an increased ventricular stress on the myocardium, associated even with abnormalities of perfusion, even in totally healthy people. So maybe that is a naturally weak spot we all have, even healthy people. And that's why it, quote unquote, doesn't mean anything. However, I have seen so many examples with non-ischemic cardiomyopathy that with, depending on which stage they were in, there was almost a continuum from RV insertion point fibrosis, then walking into the septum and then creating something that looked like a midwall sign. In almost every patient I saw with a history of a cardiac decompensation and with a midwall sign, I could actually track that back into the RV insertion point. So I think, and I would speculate, that the RV insertion point fibrosis is actually something that is very frequent in everybody who's physically active, and which is not a good reason at all to not be physically active. But in that this is the one end of the spectrum, and then the other end of the spectrum is then full-blown midwall sign fibrosis of the mid layer of the septum. So I think your data, I hope you continue the research, including adding more people and maybe follow-up data. Would be very interesting to find out early markers of when such a progression may be clinically important in terms of preventing clinical events. Thank you very much, Tilo. Great work. Say hi to Gunnar. I don't see him here. And I would hand over now to Nicole, but not before I cordially thank both of you, Corrado and Tilo, for presenting, and for Julia to also be around today. So I'll hand over to Nicole, who will announce the next journal club for August.
Yeah, thank you, Matthias. So our next journal club is on August 5th at the same time, and we are going to revisit one of my very favorite tissue properties in CMR, which is T1-Rho. So we're going to be hearing from two different groups who are using T1-Rho for different kinds of analyses. So one is going to be using T1-Rho as a potential replacement for LGE for looking at scar in patients with coronary artery disease. And then the second paper is looking at the prognostic value of T1, T2, and T1-Rho in patients with pulmonary hypertension. So if you love T1-Rho as much as I do, then join us in approximately a month for our next journal club.
Thank you very much, Nicole. So everybody have a good day. Thanks for joining, and all the best for the until next time. Bye-bye.
Thank you.